across neighborhoods, and we don't see an important influence of deprivation status. And I think that's probably because most of what we're looking at is citywide speed limit reductions and the citywide implementation of a traffic calming thing. One thing I don't quite understand is how some of the things that we've seen, like putting the speed bumps, those broke contrary to what you would have done if you were trying to achieve social equity. We put all the speed bumps in the least deprived areas. We had all the collisions in the more deprived areas. And so I can't really square what we saw with the speed bump paper alone with these bigger trends. But the bigger trends are programs that were applied to the whole city rather than demand-based or means-tested. And then I think the other thing that, that we've seen here is this suburbanization. Maybe some of this decreases from bad things as well. There is this decline in the number of children who actually walk to school in Toronto, and the number of children who cycle to school, not the subject of this paper, started vanishingly small and is threatening to vanish. So that's not necessarily a good news story, because that's not a healthy society. You know, if we don't have pedestrian mobility, particularly at the child age. The 2016 Vision Zero strategy, I think, is too new, particularly since it needed rebooting in 2019 and we had a pandemic. And so I think we do need to watch that one and find out what happens next. But this is the first paper that I've done on social equity that says we're actually able to achieve it in Toronto. And so I take that as an overall good news thing. And I think the lessons are, if you do things on a broad basis, then that's helpful. And I think the other little nagging question here is, what do we do about this suburbanization of pedestrian injury? What do we do about the 60-kilometer-an-hour posted, 70-kilometer-an-hour actual 6-lane internal highway that is our arterial road? Because we need a design solution for that. I would elevate the traffic above grade and let the children and adults walk where they naturally will anyway. But that would be designing luxury intersections, and we live in a jurisdiction that would rather have luxury cars than luxury intersections. There's somebody in the audience that I put this in for, Janet. And I'm willing to take any questions. No, it's Janet was showing me some spectacular bird photographs, and it's a bit of a fringe thing to do, but she's already figured out what that one is. Any questions at all?
I wasn't sure if we might save the questions till the end.
Sure.
So that we ensure that we do get through our speakers, and we might, come up with some more questions as others speak. So I'd like to invite Emily to take the floor. And thank you very much. So. Emily is postdoctoral fellow at York University in the Faculty of Health Science, working under the direction of Dr. Alison McPherson and Dr. Sarah Richmond, Public Health Ontario. Her doctoral work was conducted in the fields of sociology and philosophical ethics, and examined care and caring within coach-athlete relationships in youth competitive sport. However, her research scope has expanded to include road safety, injury prevention, and the built environment. Upon completing her PhD, she joined a pan-Canadian research team dedicated to reducing road-related injuries and deaths, as well as promoting active transportation. Her ongoing work focuses on accessibility, equity, and the built environment, as well as system-based approaches to safe mobility in Canada. Thank you, Emily.
Thank you for that kind introduction. So before I begin, I'd like to acknowledge that the land on which we gather is the traditional territory of the Atikamekw Anishinaabe. This territory is subject to the Robinson-Huron Treaty, and I humbly recognize the Indigenous relationships with the land that precede our gathering here today. Second, I'd like to acknowledge my privilege and positionality as a white, Western, global North researcher who uses she, her pronouns and is cisgendered. So the title of my presentation, Road Safety, Accessibility and the Built Environment, Strategies for Promoting Health Equity in 5 Canadian Cities, Municipalities. So today I'll be presenting, here we go, the results from a project. To click the thing. There you go. Thank you. Today I'll be presenting the results from a project that would not have been possible without the hard work of this author team, the generosity of numerous partners, and the support of the Canadian Institutes of Health Research, University of Calgary, York University, Sick Kids Research Institute, and Parachute. So I'll begin with an overview of the project from which these data are derived, a summary of the methods and analysis procedures, and then examples from the data in the form of qualitative excerpts. So as I noted, these results are from one objective of a larger study that focused on the links between active transportation and the built environment. The study is supported by CHASE, a Canadian nonprofit organization that is dedicated to creating healthier and more sustainable environments. There have been a few CHASE presentations throughout the conference, so this is an extension of that work. So the third objective of the study aimed to identify implementation strategies for built environment change at the municipal level to encourage AT. So more specifically, the goal of this objective was to better understand the barriers and facilitators associated with making BE changes that promote road safety and active travel. To answer this question, this research prioritized the experiences of professionals working in the fields of road safety and injury prevention in 5 Canadian municipalities: Vancouver, Calgary, Peel Region, Toronto, and Montreal. A significant finding of this work is that these professionals discussed barriers and facilitators to built environment change, specifically with regards to accessibility and health equity. So there is another set of results from this study, a high-level analysis that just looks at the barriers and facilitators, and that work is just in the works of being published. So this is a second takeaway from this data set that looks specifically at data pertaining to accessibility and equity. So the links between the built environment and people's health are well established. Unfortunately, the current design of many built environments contribute to increased health risks for children, older adults, and other vulnerable road users. It is important to emphasize that these groups are not inherently vulnerable, but instead are made vulnerable by the current design of the built environment. Thus, modifications to the built environment can enhance the safety of vulnerable road users by decreasing crash incidents and mediating driver behavior and error, while density, connectivity, and walkability can increase the built environment's accessibility. However, BE modifications are not implemented equally across communities, which highlights the importance of examining BE change through the lens of health equity. So broadly, implementing health equity means pursuing the elimination of disparities and inequalities for people occupying a variety of social locations. The World Health Organization asserts that health as a human right and defines equity as the absence of unfair, avoidable, or remedial differences among groups of people, whether those groups are defined socially, economically, demographically, or geographically by other dimensions of inequality. Further, according to the National Collaborating Center for the Determinants of Health, health equity means that all people can reach their full health potential without disadvantage due to social position or other socially determined circumstance such as ability, age, culture, ethnicity, family status, gender, language, race, religion, sex, social class, or socioeconomic status. Given the links between the built environment and people's health, it's imperative that we employ a health equity lens to highlight the disparities for equity deserving groups. So this brings us to methods. Qualitative data were collected by members of the research team in each municipality. Participants were recruited from policy and decision-making sectors, transportation, police services, public health, nonprofit, schools and school boards, and private sector. The research team used a combination of snowball and purposeful sampling techniques to recruit participants. Key informant interviews were conducted with participants in each municipality between January to December 2019, and virtual focus groups were held between July to November 2020. The original intention was to hold in-person focus groups. However, due to COVID-19 restrictions, focus groups were conducted virtually and used a third-party platform called Upwards to facilitate online discussion. So Braun and Clark's approach for thematic analysis was used to code and organize the data. This is a useful approach when identifying patterns and themes across a data set in reference to a research question. In this case, what are the barriers and facilitators to BE change? Further, thematic analysis enabled us to see patterns across the data regarding barriers and facilitators in relation to accessibility, health equity, and the built environment. So participants discussed barriers and facilitators in relation to accessibility and health equity concerns. Major barriers included exacerbated risks for marginalized groups and inequities in the BE change process. Major facilitators included equitable BE changes and strategies for inclusive consultation. For the remainder of the presentation, I'll provide some examples from the data in the form of excerpts from participants across municipalities and sectors that illustrate these themes. Risk for marginalized groups. So participants identified accessibility and health equity concerns they encountered in their work. For example, a participant from Peel Region's public health sector explained, "We know that vulnerable populations such as school-aged children, seniors, people with low SES are disproportionately impacted by a BE that does not support health and safety. Improving the BE should have more benefits for vulnerable populations because it's an attempt to reduce health inequities." Further, a participant from Calgary's transportation sector stated, "Safe means more than freedom from collision-induced physical harm. It is an unfortunate reality that people in our society are targets of physical and emotional abuse as a result of their gender, sexual orientation, race, and social class. And cars can provide protection from risks other than being hit by another car. These data illustrate an awareness of how pre-existing vulnerabilities intersect and are exacerbated by the current design of the built environment." Participants provided examples of specific vulnerable groups and how their health is impacted by the current built environment. For example, a participant from Vancouver's public health sector addressed concerns for people with low socioeconomic status. In neighborhoods that have the lowest economic status, the infrastructure is poor. There is lower prevalence of sidewalks or separation for traffic speeds. Traffic speeds are often higher, there is more industrial than commercial traffic, and the crosswalks are not as good or signalized. In addition, a participant from Calgary's nonprofit sector identified concerns regarding the lack of BE changes in neighborhoods with new Canadians and immigrants. Communities that have a higher proportion of new Canadians or have a higher proportion of people experiencing low incomes, we know that they tend to be underserved when it comes to active transportation infrastructure. Participants also discussed concerns regarding the health and safety of older adults and children, women and caregivers, and people with disabilities. These concerns centered on the design of the built environment, particularly with regards to adequate lighting, walkability, and connectivity. Participants described the BE change process and how communities can meaningfully contribute to the design and location of desired changes in their neighborhood. However, traditional approaches to community consultation, such as the complaints process and open houses, are not accessible for all. For example, a participant from Vancouver's public health sector explained how the city prioritizes BE changes. A lot of it is complaints driven. So if there's a community where they have the capacity to complain, or the knowledge on how to complain, they can get elevated. But of course, that favors economic, more socially privileged groups. And evidence shows that those are the ones with lower risk for injury. In addition, a participant from Calgary's nonprofit sector commented on the inadequacies of the open house strategy for community consultation. This model of having open houses and expecting people to come to you is a waste of time. You're always going to get the same people, which is not representative. Overall, participants were critical of the traditional consultation methods, specifically because they are not accessible for all road user groups, especially those who already experience disproportionate health risks due to the current design of the built environment. So, participants also identified changes to the built environment that would promote health equity and access for equity-deserving road users. For example, a participant from Toronto's school board sector noted the importance of connected pedestrian networks, ensuring that sidewalks don't end abruptly. While a policymaker from Montreal listed auditory signals, the installation of tactile paving stones, and reconfiguration of the geometry of intersections as necessary built environment changes that would enhance the safety of vulnerable road users. Lastly, a Peel Region participant from the public health sector stated, ensuring there is lighting along the pathway or walkway to transit stops to encourage users to feel safe and use the pathway regardless of the time of day. So there's quite an awareness among these group of professionals of what's needed, the changes that are required, but of course they experience barriers in their own work with getting those changes made. So strategies for inclusive consultation. Recognizing the inadequacies of current consultation strategies, participants discussed some more inclusive options. For example, a university researcher from Vancouver explained, it might have to look differently for different communities. It's not a one-size-fits-all approach. In some communities, you're not going to get anybody out to public forums. You're not going to get meaningful feedback. So you have to actually know what will be most meaningful for that community by having multiple pathway points for access. Maybe it's social media, maybe it's public forums, or maybe it's a community event. It's got to be diverse and it's got to be grounded in the community. This illustrates the importance of not only changing the built environment according to the particular needs of communities, but the consultation process must also be adapted to suit the needs of equity-deserving road users. A participant from Montreal's nonprofit sector described their approach to inclusive consultation. Our approach puts users at the heart of the process to ensure that they have a voice in decision-making. This does not mean that all opinions and ideas are necessarily equal or considered. However, this method promotes dialogue between the parties, encourages empathy exercises, and often allows participants to better understand the position of others, especially the most vulnerable, and the decisions that are made. Finally, a participant from Vancouver's transportation sector explained the importance of inclusive consultation processes for equity-deserving groups. Rather than just asking for more consultation, asking for consultation from specific groups you are not hearing and then elevating those voices when they do speak up. This would give us direction to put consultation funding to these groups and ensure those who do take the time to step forward that they will be heard. This is an example of an approach of a more inclusive consultation approach that aligns with a health equity strategy. So I'll conclude with a brief discussion and some key takeaways gleaned from this research. The results from the study provides insight from Canadian transport and injury prevention professionals regarding the need for built environment changes that serve equity-deserving groups. Further, employing a health equity lens heightens concerns regarding the current state of the built environment and the processes that guide change. So there are several key takeaways from this research. First, the current design of the built environment contributes to the disproportionate health risks for vulnerable road user groups. Second, it is important to include equity-deserving groups and communities in built environment change processes. Third, traditional consultation strategies, such as the complaints process or open houses, are not accessible for many equity-deserving groups. 4, there is an urgent need for a shift in the built environment change consultation process and to ensure that equity-deserving groups are well served by the changes. And lastly, a health equity approach to consultation strategies is grounded in the understanding of the values, identities, and lived experiences of equity-deserving groups, as well as the economic, social, and political context. Overall, The concerns and strategies highlighted by this research ought to inform decisions regarding built environment change. When considering the implications for health equity and the well-being of all road users, change going forward is pivotal. So just briefly, a few limitations of the study is that purposeful and snowball sampling techniques may have resulted in some more similar views and opinions about barriers and facilitators to PE change across municipalities and sectors compared to random selection. In addition, the semi-structured interviews were conducted by different members of the research team in each region, and thus the probing questions varied and elicited slightly different responses from participants. Lastly, the positionality of each researcher may have affected the participants' responses. I have my references there, and thank you very much. Oh my God, this is no problem. Yes, and now I'm here doing this. I'm trying to detach and detangle. But this one. I don't even see. There's one over there though. Oh, she's just looking for a plug for her computer. She's over there. Oh, I haven't done this one.
This is the right side and that's the left side. Just put it over, yeah. Over the, yeah. Typically it should go over your ear. It doesn't have to go. You want me to?
I don't like these.
Yeah. And the mic.
Oh. One more try. It's the hair that gets
yeah. It's over. Yeah. Perfect. And then adjust the mic too.
How are we doing?
We're good.
Okay.
Okay. So how do you change the slide?
I'd like to introduce Linda Rothman.
Thanks.
So Linda is an assistant professor in School of Occupational and Public Health at Toronto University. Adjunct scientist in child health evaluation sciences at the Hospital for Sick Children, and an assistant professor at Lavallire School of Public Health, University of Toronto. Dr. Rothman is an occupational therapist and has clinical experience with children. Her area of expertise in vulnerable road user injuries in urban environments as a public health issue, and has been working in this field for over 20 years. He is an investigator on an internationally renowned planned communities in researchers studying children's road traffic injuries. The recent research projects include studying the effects of the COVID-19 pandemic on road traffic volumes in 4 Canadian cities with a social equity lens, which includes the evaluation of new road design modifications such as cycle tracks, reduced speed limits, and automated speed enforcement.
Thank you, Mavis. Hi, everybody. I know it's getting late in the afternoon and I appreciate everybody being here. There's going to be lots of references to other things that people have talked about already today and yesterday. But today I'm going to be looking specifically at, it's bumping around, active transportation. So we're not actually looking at collisions in this presentation. That's the next stage of the study. But we had quite a great team, as usual, working on this. A few of us from Toronto Metropolitan University, which is used to be called Ryerson, including somebody from School of Urban and Regional Planning, SITKID, York University, INRS in Quebec, and Parachute. And I don't think I'm missing anybody else. This project was funded by CHR. It was a one-year grant looking at specifically active transportation and social equity and collision and social equity. And it was done as part of, we talk a lot about Naomi Schwartz at this meeting, and she's not here, but a lot of the work was done by her, and now Sarah's very lucky to be working with her at PHO now, and we're very jealous. So, Naomi, you don't know what you're missing. Okay, so we all know the benefits of active transportation. There's an overall increases in physical activity associated with kids walking to school. There's actually been some studies looking at improved cognitive function and academic performance. We know it's good for mental health and community cohesiveness. It contributes to long-term active lifestyle over time. So if you're an active kid, you're more likely to be an active adult. There's a long-term reduction in chronic conditions with physical activity, and just like general, air pollution, noise pollution, it's good for our environment to be out of our cars. I know this is one of Andrew's favorite studies, and I don't know how to pronounce the author. Cilius Morales looked at, there's a population-based prospective study that came out pretty recently in 2017 with over 263,000 participants in the UK. And they actually looked at the association between active commuting and different chronic diseases. And this was not in kids, but I just wanted to stress the importance of the study, number one. And number two, how they actually found associations, marked associations with cycle commuting with lower risk of cardiovascular disease, cancer, and all-cause mortality. And walking commuting was associated with lower risk of CVD or cardiovascular disease. So this, active transportation really does make a difference in terms of chronic conditions later on. Somebody earlier mentioned, I think second presentation, that most children are, the active transportation, as Andrew, has been going down in kids over time. Most children do not meet physical activity guidelines of 1 hour of moderate to vigorous physical activity per day. And if you look at this little chart, I think it was done, the original one was done by Ron Buehling, who we mentioned before. You can see from 1986 to 2016 that over the GTHA, the Greater Toronto and Hamilton area, active transportation in kids went down from 56% to 37%. We also, with a lot of our CHASE studies, we talked about the CHASE study across Canada, there's very large variability in active school transportation between schools. We've done lots and lots of direct observational data collection over the years in Toronto, and we pretty well consistently get an average of around 67% of kids arriving to school with active transportation on average, which was quite a bit higher than we thought when we started on this work. But then when you actually look at the range, it's huge. Some schools only have a quarter of the kids showing up walking and cycling, and others almost have all the kids showing up by walking and cycling. And always the perception is that the kids in lower income areas are walking more. That's not always the case in Toronto. Our downtown core tends to be higher income, a lot of the areas. And lots of kids are walking in those areas as well. So it's not typical patterns, I don't think, in Toronto that you see maybe in the United States with some of the studies where it's much higher with lower income kids. Although we'll see, we're going to look at these results. So we did, again, there's a study by McDonald that said higher AST was found in low income areas. We did find some evidence in a previous older study that there was higher active school transportation in low income areas, but we're going to look at this closer right now. In terms of ethnicity and immigration status, There's all sorts of mixed results. In the States, they show higher active school transportation in Black communities. One of our studies showed that higher active school transportation was evident in areas where it had a high proportion, or schools where English was not the primary language with a lot of the kids. So, and we were kind of curious about how the built environment kind of related to all this in terms of the Toronto schools. So we looked at walk score, and I don't know how many of you are familiar with the walk score. Lots of us use it in terms of when we're looking to buy a house, how walkable the neighborhood is. It looks at things, it's kind of a composite score of things like how close you are to amenities like shops, recreation, and schools, population densities, intersection density, and how far it is to walk along the street routes. You can Google walkscore.com, put in your postal code, and find out how walkable your neighborhood is. And you can see it goes from 1 to 100, from very car dependent at 0 to 24, all the way up to what they call walker's paradise, above 90. When you look at these measures, you know, the question is, are these actually pertinent for kids? A lot of these measures kind of tend towards walkable environments in terms of adults. So we wanted to see if walk score is actually related to active school transportation in a child population. So the research objectives were to examine the influence of area level social factors on active school transportation in Toronto schools, so within a 1,000-meter walking distance of a school. And we looked at things like the material deprivation, ethnic concentration, proportion of recent immigrants, and proportion of visible minority. And some of these were from the Ontario Marginalization Index, and a couple of these variables like visible minority were from the census. And we wanted to look at whether or not the neighborhood built environment around schools influences the relationship between social factors and active school transportation. So the two things we focused on in terms of built environment was the walk score and also density of multi-dwelling homes, because consistently in all the studies we've done, we found that, you know, the more dense the housing is, the more walking goes on. So we felt that was an important thing to control for. So again, part of the CHASE study and some additional data collection we did, we had counts at schools by 2 trained observers in the spring of 2018 and 19 at publicly funded schools, junior kindergarten to grade 8. And again, this is just the Toronto results. We didn't do the study in all the other cities that were involved in CHASE. We could, but we didn't, not yet. And we looked at the percent traveling by active commuting, walking, cycling, skateboarding of all children arriving, excluding the school bus. So our denominators was everybody arriving to the school by car, basically, and active transportation, but not by school bus. And we had 105 schools across Toronto that we collected these data. The outcome was the active school transportation rate. Our exposures, again, were these measures of social, I guess, basically marginalization. Built environment variables are, again, walk score, multi-dwelling density, and we did a multivariable beta regression for each social indicator separately, and we tested some interactions. And I know there was a comment on whoever refereed or abstract about what is beta regression, but it is a type of regression that you can do using a proportional outcome. Okay. So here is the map of the schools that were involved in the study, and you can see they're pretty widely dispersed across the city. And again, we got our AST rate. This time it was 64%, not 67%. And the range went from 24 to 99%. And the red were the lowest and the green were the highest. So without going into too much detail about the modeling, these are the main results. We did find that recent immigration, less than or equal to 5 years, or higher ethnic concentration was significantly related to more AST. So there was an odds ratio of 1.5. The walk score was also related to more AST with 14% greater odds of walking with a higher walk score, and also multi-dwelling density. So we did find that walk score was related to active school transportation. There was less of an association with the study found for material deprivation, or as we may call socioeconomic status, and visible minority. We actually found the recent immigrant was quite an important, had quite an important relationship, which is something we need to look at in more detail. What is it about being a recent immigrant means that you walk more? And then in our next study, which we're finding out is actually means that you're getting hit more as a pedestrian. So that might be like room for some really great qualitative research. This was kind of an interesting graph we did of the interaction between walk score and active school transportation when looking at the different levels of material deprivation. This was the clearest one that I wanted to show you. If you look along the green line and the green bar, that's low walk score. If you look along the reddy orangey line, that's medium, and high is, wait, I have it backwards. High is the green and low is the blue. And you can see if you follow the top green line across where it's high walk score, everybody is walking quite a bit. It's like 70 something percent. So whether you're least deprived on the bottom axis or the most deprived, everybody's kind of walking equally in walkable neighborhoods. If you look on the bottom, the blue, you can see that if you're least deprived, so that means you're higher income, you're walking a lot less at around 40% than you are if you're in the most deprived areas, which is back up to around 70%. So you can see there's really a difference depending on the walkability of who's walking and who continues to walk. So just to summarize, there are higher odds of using active school transportation with greater recent immigrant population. We did find that walk score and multi-dwelling density are associated with increased AST. In highly walkable environments, children both at high and low deprivation areas and also recent immigrant had the similar pattern, are walking at similar rates. And in less walkable environments, children in high deprivation areas walk more. So what does this mean? Children in more deprived areas will walk regardless of walkability. Children in low deprived areas, so higher income, will miss out on some of the benefits we talked about in terms of back to school transportation. So people are getting affected on both sides of this. The big question that I had at the end of the study is these traditional measures of walkability, are they actually associated with safety? None of those variables were really all that related to safety. And we tend to talk about walkability and safety in the same sentence. So are children in more deprived areas walking where it's less safe? We don't really know that right now. I mean, we do from some of our other research, but I'm really wanting to look, our next little piece of work that we're going to be doing in the fall is looking at the relationship between walk score and actual collisions. Because just because something's walkable does not necessarily mean it's safe for children. Whether they're close to lots of stores, does it really matter in terms of child safety? I don't know. There's important policy implications that emerge from this research related to equity in active transportation, and it must be ensured that children in more marginalized neighborhoods also be provided with walking environments which are both enjoyable, and then we'll see about the safety aspect. I think that's it. Thank you very much.
That was very good, thank you, Linda. Sorry, oh, sorry. No, sorry. Just wait one moment, yeah. I volunteered to moderate the session because it is something that I don't really know a whole lot about. I've heard the occasional presentation. It certainly isn't any area of work that I have been involved in. But I am just amazed at the amount of research that is going on in this area. And I'm just sorry, I'm going to hold Martin up today, but when it's my age, you sometimes forget what you want to say. So I just say what I remember. I live in the villages of Vancouver, and I'm sure it's as well. The growth of how Vancouver and its neighbouring municipalities are doing is quite shocking to me, actually, because whilst we are providing for very good transportation that's linked to cycling or bus or whatever, I don't see the presence of parks, schools. Are there not going to be any children that go into these high-rise apartments? Because I never see them on even about the here. And that's what it concerns me when I hear about this, special experience. These are the things I think about. So if we're ready, we'll listen to Martin, and then then we'll have some questions and a bit more discussion.
Good afternoon, everyone. It is my pleasure to present you work that I've conducted with Louis-David Beaulieu on motor vehicle collision among Indigenous people and intervention for improving road safety, a narrative literature review. Unfortunately, I couldn't make it to Sudbury for the conference due to a canceled flight to Sudbury. I wish I could have been there with you all as a first conference held in the last 2 years in presence. But let's hope that this discussion and the results that I'll be presenting today are of utmost interest for you, and I'll be pleased to answer any questions by email, and my email will be at the end of the presentation. First and foremost, I would like to acknowledge that the Université du Québec à Chicoutimi sits on the Première Nation des Pequot-Anishinaabe, which is the one of the First Nation surrounding the university and the Saguenay region where the university is on. Also, and importantly, the Atikamek-Sheng-Anishinaabe of Sudbury, Ontario, where the conference is held by the Treaty of Robinson Supérieur. And these are interesting, but not only interesting, but of utmost importance for us to acknowledge that the research we're conducting is also on the territory of the First Nation of Canada. But why addressing this important challenge is that there's a consideration of road safety for all. When we look at motor vehicle collision, we know that it accounts for a disproportionately large percentage of fatalities among BIPOC people. And by BIPOC, we mean here as the left corner, the upper left corner, the Black, Indigenous, and people of color population, and particularly among Native American. These are data from the FARS data, so US organization. But similarly, we have seen that these results are found in Canada as well, where the rates of deaths and injury for motor vehicle collision are twice as high among Aboriginal population than the general Canadian population overall. And therefore, even though we have put numerous efforts into improving road safeties in Canada over the last 2 decades, and especially with the World Health Organization, we do have to consider that they do face important challenge in terms of safety for them. But why should we act in terms of prevention is that if you look at the figure presented here on the slide, you look at the rightmost side of the slide where do happens collision. And however, when we only address the questions of collision, we seem to forget that there's numerous steps and numerous levels that can be addressed prior to the collision occurring, and that efforts should be made in the prior end into acting in terms of prevention, either reducing the impacts of collision using airbags and the structure of the vehicle, but also with the advance of technology in the past recent year with the advanced safety system, action of the driver, but more importantly, all the prevention and the collision mitigation that we can put forward, and especially before a collision that could occur. So the objective of the work that I'm presenting to you today is the merge of collaboration between myself and Louis-David Beaulieu, who's a researcher in physical therapy at UQAC, working with me at the Department of Health Science, who specialize in the rehabilitation of people suffering from cardiovascular disease and stroke. The first objective here is to document through a narrative literature review the difference, practice, and place among communities of First Nation, Métis, and Inuit with regard to mobility and transportation. And secondly, but more importantly, we aim to build upon this review to draw a portrait of the continuum representing by driving, from the access to driving license to the eventual cessation of driving among the community. To do so, we did an extensive literature search where we did look at motor vehicle collision among the Aboriginal communities and the First Nations of Canada. For the narrative, we did look into PubMed, IAC Web of Knowledge, Google Scholar, with multiple keywords using a Boolean typical approach that we would do for a narrative literature review. It is important, though, to note that here, even though there's interesting work that has been done here in Canada, and these are examples from the team of Desipria and Ian Pike, the main core of the presentation we'll address today is, yes, on road safety, but more specifically on the driving per se. So there's been work and studies conducted on the use of child passenger safety or some types of motor vehicle collision of off-road reserve crash. But here we're not going to focus on the passenger of the vehicle per se, which is often more tailored towards the younger portion of the driving population, but we're mostly going to focus on the person who's driving the vehicle, and therefore mainly teenagers and all adults growing up. Out of the identified publications, so out of the 131 papers I initially identified, unfortunately, only 5 were selected for the current review that only addresses the questions of driving, as I've just said. 1 was addressing the access to driving, and 4 of those papers are related to the topics of driving under the influence, which I'll discuss later. The literature review was sorted into a summary of the general ideas and is presented for discussion, but we also outlined some of the sectors that are lacking the important factors associated to road safety. First and foremost, we should also present the presentation here in regards of road safety. Here I'm using, as a sake of the presentation, the Olnagel model, which is, if you look at the leftmost side of the slide, we have the collisions, the injuries, and the deaths related to motor vehicle collision. But we also have to consider it as that there's multiple layers of interaction here involved. As number 1, there's the individual who's driving. Number 2, the driving context and the vehicle used in this system. Number 3 is the road infrastructure. For the organization, when all of this is associated with a company or an organization. The number 5 is the laws and regulations surrounding road safety legislation and the Quebec, or in our case here in Chicoutimi, the Quebec Road Safety Code. And as a general umbrella over all this, there's the socioeconomic and cultural environment associated with the individual. All those comes from proximal factors on the leftmost side to more foreign and further away factors that influence road safety, and they should all be considered when addressing the questions of road safety herein. So as part of the results, the first paper identified was the one by Cullen et al. In 2018, is that what they've identified is that the first step, actually, the access to driving for younger individual or older individual that might have never got their driving license first, is that it's the hurdle for assessing the work market. So for most people, the importance of accessing driving privilege is also an important challenge if the accessibility remains one of the biggest challenges for providing proper education and training for obtaining a driving license. For some communities, these services rarely exist, or they're often scarcely distributed along the year. So there's only a presence once in a while. So this has to be considered, and this has to be retaught in terms of how can we train and educate people to drive safely. The second step, and the one that has been more addressed looking at that narrative review, is the maintenance of driving privilege. Unfortunately, there's no such training as the maintenance of driving privilege. When we say maintaining the driving privilege, is that we have, or it was never addressed as a driving curriculum that could have looked at maintaining the driving privilege or enhancing or maintaining someone's driving skills, like we have seen in numerous studies conducted in the US, in the States, or in Europe. Even in Canada, here, some interesting work conducted by Michel Porter, Michel Bédard in Ontario and in Saskatchewan and Manitoba regarding the improvement of older individuals. Such studies has never been conducted among Indigenous people. There's other programs that have also been developed to address the problem of driving while impaired, Some of them, the paper of works of Fitz, in 2016 and 2017. But interestingly enough, we have also seen in the review that people are also inclined to report attitudes or road safety behavior similar to the rest of the driving population. This was reported by the paper of Cullen et al. In 2019, which is interesting here is that we can clearly see that people will report those dangerous behavior as it is done in other jurisdiction or other direction. But what is important here is that people don't necessarily tolerate these behaviors that are not inaccurate, but that are not safe for others. There's also the questions of the driving cessation and the maintenance of mobility. There was a previous review done by Short, Musquash, and Bedard, where a total of 11 studies were met the inclusion criteria, including, unfortunately, just one Canadian study and 10 non-Canadian studies. Most of the studies that were conducted among Indigenous or Aboriginal people have all been conducted in Australia. What they've seen is that their successful intervention component should also include focus group training community members as leverage to promote that road safety, educational activity, and distribution of safety device with local law officials. The potential barriers, though, were the lack of incorporation of cultural and contextual factor, the enforcement factor depending on where the community is located, and some methodological limitation, as we have seen as well in the current review. So just as an example here, we always face the proximity to service. So here in the example, for similar size of population, I'm presenting you the yellow dot, which is Mastoyache, a close Innu community close from Saguenay, from UQAC. There's also Obidjwan, which is the blue circle there on the left of the Quebec map. And if you look up north, you have Kuujjuaq. So for about a little higher than 2,000 people as of community reported here, we can clearly see that in terms of distance, as an example, the community of Mastoyache is directly located next to the city of Roberval, which provides service for driving education, hospital, and so on. Whereas if you look further west towards Obidjwan, Roberval is actually a city that is 275 kilometers of distance. And if we compare that to Kuujjuaq up north of Quebec, there's a road infrastructure there, mostly used with stop sign. But unfortunately, if you want to go outside of that community of Kuujjuaq, is that either you take a boat and you'll do a round trip around the Labrador coast and the Newfoundland coast to come back to Quebec area. Otherwise, you'll have to take the airplane to fly back to Montreal or Quebec as an example. So these are challenges that despite having similar size of population, they clearly don't have the similar access to safe road infrastructure, but also the service that are surrounding road safety, either in prevention, as I've said earlier, but also in the questions of if in the unfortunate event that there would be a collision, it is clearly not as well served in terms of hospital and emergency settings across Quebec. What the review and the other papers that were identified have clearly example is that there's underserved sectors for the native communities. Typically, most of the effort have been done in education, enforcement, and engineering. But what was clearly highlighted by the work conducted in Canada with the other review that was identified in 2011 is that we clearly missed the sector of the evaluation, but more importantly, the empowerment of our communities to produce, but more interestingly, to provide more efficient and more tailored intervention to improve road safeties that not only consider the vehicle, the person, and the environment, but also the contextual and the socioeconomic sectors surrounding road safety for these communities. We can clearly believe that the prevention can be done by preventing, promoting, and preserving the life of people. By preventing, we aim to prevent those collisions that happen at the rightmost side of the figures that I've showed you earlier, by preventing the collision at the forefront. So just preventing risky driving, preventing the bad usage of certain types of vehicle among the communities. And by doing so, by adopting a preventive measures of road safety and by developing appropriate program for these communities, we clearly believe that we can reduce the burden of road safeties among these communities. As of conclusion, we have clearly seen that there's scarce literature and researches on these important topics. It is important to consider road safety for all. Most of the studies, and not only for First Nation people and Métis and Inuit in the case of Quebec, but we have clearly seen that often when we go outside of bigger city center, there's less or there's few studies in regards of road safety, and that most of the programs that are developed for huge city center like Toronto, Vancouver, or Montreal, they're completely not tailored for more spread and more sprawl areas. There's clearly a collaborative effort that needs to be done to improve road safety and mobility for all. And that's what we're aiming with my colleague Louis David, is that with the combination of efforts in road safety and the combination of the efforts that Louis David is doing for improving the care of people who suffer from stroke, we aim to develop and better design intervention and road safety for all. Eshe, merci, thank you. So this is what concludes my narrative review, my presentation on the road safety and intervention that have been conducted for First Nation, Métis, and Inuit communities among Canada. As we have seen, there's less or there's scarce that has been done, but let's hope that we can improve the road safety for all, and especially among this community that requires it. I'll be pleased to answer any questions by email if you have so. Have a good conference. Thank you.
Very good. Very good information. And for those of you who don't know Martin, I should tell you something about him. Martin Lavallire is a professor of kinesiology at UQAC. He was also a research fellow at the MIT Age Lab, where he worked as a postdoctoral researcher from 2013 to 2015. From 2015 to 2016, he worked at HEC Montreal for a second postdoctoral position, where he conducted research on emergency responders and their implication in road collisions. Dr. Lavallire brings extensive knowledge in human motor control and learning in human movement analysis. He received a BSc, MSc, and PhD in kinesiology from the University of Lavallire in Quebec, Canada. For his PhD, his work aimed at evaluating whether an in-stimulator-based training program combined with driving-specific feedback on what driving behavior to one of the drivers. He also evaluated the impact of a similar training with people who suffer from traumatic brain injury. During his PhD, he also worked as a road safety consultant for the CA. And Martin has recently been a member of the board of directors at Quest and has just retired from that position. So we've had 4 excellent presentations. And I'd like now to give us, we have a bit of time, so we've got about 15 minutes. If somebody would like to start the ball rolling, either with a comment or a question. And do we need to, is anybody listening to us? No. Oh, no. So no, figure out the microphone? Yeah. Okay. It's too small enough. I have a question for Emily and Linda, and they're both around the theme of language. I'm curious whether or not the concept of language barriers came up when you spoke to people, because just sort of anecdotally, I work for the state law, and when we put in new policies